Early prostate cancer has very few symptoms. We normally pick it up with a blood test called the PSA, or occasionally we can pick it up if the gentleman has urinary symptoms. This might be difficulty passing urine or passing urine more frequently, or occasionally pain in the bladder or infections. But the most common way these days is with a blood test called the PSA. This stands for prostate specific antigen. You can get this from your general practitioner normally fairly easily. PSA goes up in certain diseases of the prostate. It is not specific for prostate cancer. It can go up in men with enlarged prostates, and all men get larger prostates with increasing age. It can also go up in infections relating to the urine or the prostate. The risk of prostate cancer increases with increasing age. You should get a prostate exam if you're concerned about prostate cancer, or if you have a strong family history of either breast or prostate cancer. You can get the PSA tested via your general practitioner, and we generally advise, if there is a family history, to have your PSA blood test done at the age of 40. If there is no family history, it's thought reasonable to have it done at the age of 50. The most important thing is actually to know your baseline. Because the PSA may be proportional to the size of your prostate, it goes up in bigger prostates. And therefore, once you've established your baseline, a rise is the most concerning thing rather than the actual value itself. Prostate cancer is the most common cancer diagnosed in men. We find it with increasing age. It's normally found at a very early stage, particularly in younger men. Sometimes in older men, we find it at more advanced stages. A man referred to see me with a raised PSA will be seen in the consultation room, and we'll have a chat about your general medical history. Once we've done that, it's important to examine the prostate. And following that, it's likely that an MRI scan of the prostate will be requested. An MRI scan takes about 30 minutes and is done in the radiology department of the hospital. The MRI scan gives us several key pieces of information. Firstly, it will give us information about the size of your prostate, and this means we can adjust the PSA for the volume of the prostate and calculate something called the PSA density. The radiologist, who is the doctor who will look at the MRI scan, will also look in detail inside the prostate to see if there are any abnormal areas that might be associated with increasing risk of prostate cancer. If he or she does see abnormal areas within the prostate, or if the PSA density is high, it is likely that a prostate biopsy would be recommended. This tends to be done under an anaesthetic in the operating theatre, and it's then possible to fuse the MRI images with some live ultrasound images of the prostate generated in the operating theatre. This allows us to target the areas of concern within the prostate more accurately. You normally go home the same day, and the samples are then sent to the laboratory for analysis, and we will see you back shortly with the results of those to explain the findings. When I see you back with the results, one of the key pieces of information is something called the grade of prostate cancer. This is a measure of its aggressiveness. Many prostate cancers do not need treatment, and many do not need urgent treatment. Some prostate cancers, which are of low aggressiveness, can be monitored closely, often for a very long period of years, because they tend to progress very slowly. This monitoring process is something called active surveillance and involves regular testing of the PSA test, and if there are any concerns, doing periodic MRI scans and occasionally a further biopsy of the prostate to see if there has been any progression of the prostate cancer. If there has, that man would move over to active treatment at that point. Initially, if the grade of the prostate cancer was higher, indicating more aggressiveness, treatment might then be recommended now. And those treatments vary between surgical treatments, where the prostate is removed, these days usually with keyhole surgery with the aid of robotics, which speeds up the recovery and usually minimises many of the downsides of removing the prostate. Or alternatively, there are options that involve radiotherapy being given to the prostate. This does not involve surgery. There are usually two main options of giving radiotherapy. Firstly, brachytherapy, where radioactive seeds are put into the prostate, and the prostate cancer is killed from within, so to speak, by these grains of radiation. Or secondly, the oncologist may recommend external beam radiotherapy, which is given normally over several weeks in a radiotherapy suite. If prostate cancer is caught and treated early, the survival rates are excellent, and men can normally expect to live a very active and normal life expectancy. If it is caught late, there are many treatments these days, and over the course of my career, there have been advances in chemotherapy and many other drugs that can treat advanced prostate cancer. So even in men with advanced disease can have much longer life expectancy than was the case 10 and 20 years ago.